Welcome to another episode of Fork Candles, where we explore medicine, child neurology, and critical appraisal skills. As always, this is an educational endeavor and should not be interpreted as medical advice. Each patient and situation is unique and should be addressed by your personal healthcare provider. Today I want to talk about addressing the conflicts that arise from therapeutic noise. Here I am defining therapeutic noise as the variability in physician choices without any considerable differences in patient baseline characteristics or personal preferences. For example, this study here on the left was looking to validate an anti-seizure medication algorithm for new onset epilepsy that took into account patient characteristics and seizure type. They did a chart review of over 400 patients and let the algorithm choose which medication would be best for them. They then compared that to what the patients actually got. A quarter of the patients received medications that were deemed less than favorable by the algorithm, and those patients had a 10% greater treatment failure rate. Even still, only 40% of the patients received what was classified as a Group 1 favorable anti-seizure medication. Over here on the right is the survey of 399 different physicians and what their first-line treatment is in anti-NMDA encephalitis. As a medical resident, I experience this on those Friday afternoons when a new attending is about to come on service. If I wait 20 minutes to staff a consult with the new attending, I may be giving a different recommendation than if I don't wait those 20 minutes despite nothing changing about the patient at all. While discussing causes and remedies to therapeutic noise is interesting, today I want to address the conflict and tension that arises out of this noise. We are tasked with helping others live better and longer lives, which makes this one of the most rewarding disciplines. However, this common goal is also why we have some of our most heated disagreements. If you believe your medical decision is right and I am wrong, then you believe I am actively harming a patient. There is no escaping the high-stake implications of our disagreements. Those that advocated for antiarrhythmics for patients with arrhythmias post-MI throughout the 1980s were harming their patients, as seen in the now famous CAST trial. Those that push for high-frequency oscillatory ventilation over conventional ventilators in adults with ARDS were harming their patients, as seen in the Oscillate trial. It is easy to fall into a crusader mode and paint others as good or bad when you disagree with them because the stakes are so high. Some may paint me as unsympathetic to those that suffer a cardiac arrest because I do not believe targeted cooling improves outcomes as shown in the TTM1 and TTM2 trials. Or some may say that I lack empathy towards patients with pediatric migraines because I believe the evidence shows that topiramate and amitriptyline are no more beneficial than placebo as shown in the CHAMP trial on the right. Yet, would I have been unsympathetic to patients suffering from pneumonia in the 1700s if I didn't prescribe the various tinctures or bloodletting? Of course I recognize they are suffering and my heart goes out to them. We cannot confuse our differences in solutions as differences in goals. Our differences are in degree, not in kind. To turn down the temperature of our disagreements, I believe we need to take a different mindset towards what it means to be wrong. I want you to take a moment and think of instances where you disagreed with someone's treatment of a condition and then new evidence came along and convinced you to change your mind. This is not an easy task because that means that we are admitting that we were advocating for things in the past that were harming our patients that we care about deeply. While you are letting some of yours turn over in your head, let me give you a brief tally of my misadventures in COVID. I predicted AstraZeneca vaccine was going to be better than Pfizer and Moderna. Wrong. I then thought that CureVac, the German mRNA vaccine, would show the same efficacy as other mRNA vaccines. Wrong. I thought vaccines would take far longer to develop and be less effective. Wrong. I bet against dexamethasone. Wrong. And I whiplashed a few times with the antivirals molnupiravir and Paxlovid. Bringing this back to neurology, in 2019 I made a whole video on why I did not think that the pediatric status epileptic trials Concept and Eclipse demonstrated that phenytoin and levetiracetam were equivalent as second-line agents. However, at the same time, I was starting to realize that my ability to dismantle or prop up a study had far exceeded my motivation to see the world as it is and not how I wanted it to be. This motivation is what Julia Galef terms the scout mindset. I knew the ESET trial was about to be published with their results of status epilepticus and second-line agents, so I set a goalpost that I wouldn't move after I saw the results. Here is the posterior probability distribution of the ESET trial. I now agree that there is unlikely a meaningful difference between phosphenotoin and levetiracetam, and knowing the logistics of most emergency departments, if my son was in status epilepticus, his rescue plan would be benzo-levetiracetam. On the face of it, it seems rather cliche, but knowing that it is good to change your mind when better evidence comes along is different from actually doing it and how to do it effectively. Knowing exercise is beneficial is different from actually doing it. It's very easy to go on a bike ride and pedal very little and fool yourself into thinking you have exercised effectively. Listing all the times I have been wrong might be helpful in signaling that I am someone worth engaging in with, as I have proven I can be persuaded, but it is the wrong way to think about being wrong. If a weather forecaster says there is a 70% chance of rain and it doesn't rain, it is impossible to judge how insightful that forecaster is based on that one day. She gave a 30% chance it was not going to rain. We would need to look at all the times she said there was a 70% chance. If 7 out of the 10 days it rained, then we would say she is well calibrated. These are graphs from Philip Tetlock's book, Super Forecasting. Imagine these two graphs are of doctors forecasting the chances of medical interventions working. On the left is someone that is not calibrated and underconfident. When she says an intervention has a 20% chance of working, it works about 50% of the time. On the right is the opposite problem. When she says an intervention has an 80% chance of working, it only works 50% of the time. The goal is to be highly calibrated with high resolution, which is the graph on the right. The person on the left is well calibrated but not very helpful, as it's pretty much a coin flip when they give a prediction. Shifting my focus from any single intervention to one where my goal is to improve my calibration and resolution frees me from digging in my heels, as it forces me to give a probability to the possibility I am wrong. If I give a 30% chance of something working and it ends up working, great. I don't need to defend the 70% chance that it wouldn't. My identity is not tied up in any one intervention. I am not bothered by levetiracetam being better than another drug or topiramate not working in pediatric migraines. My course correction is built on many predictions which arise out of thought processes. If I am poorly performing, I need to improve the thought process. A way that I can start practicing this in medicine is by trolling clinicaltrials.gov. Here's a snapshot of my spreadsheet of the trials investigating CGRP antagonists for pediatric migraine. I assign various probabilities based on what I think the results will be. I can then later measure my calibration and resolution by something called the Breyer score. These predictions here are just placeholders, as I am working on headache frequency model that I want to complete before I give my actual predictions for the chronic and episodic trials. And the outcome column is obviously made up because these trials have not been completed. Additionally, I should be updating my predictions as each new trial is completed, as it gives me better information about the next trial. However, I should make sure that I keep track of all my changes I made along the way and see if I am properly adding new information to update my predictions. For acute migraine, you saw that I gave a 90% chance that rimegepant will show a benefit over placebo, but I would only give a 30% chance that rimegepant would be better than triptans, which is currently the standard of care. I would give a 65% chance that there would be no significant difference, and a 5% chance that rimegepant would be worse than a triptan. So in this view, the acute trial doesn't really add much clinical information because I don't know how it does against the standard of care. In the prevention trials, I would review their results differently because I currently believe that there is no good evidence for the current standard of care. And therefore, if their results are positive in those trials, then these should become the first-line agents for prevention in pediatric migraine. This was a bit of an aside because what we're really focusing on is how we can go about practicing improving our calibration and resolution. What all this prediction, updating, and readjusting my thought processes will do is help me create a path of least resistance to allow me to see the world as it is and not the way I want it to be, which is the first step in being able to resolve conflicts. Here I have only used randomized controlled trials to update my predictions of what works, as ultimately well-conducted randomized controlled trials are the arbiters of what actually works. That said, there are 3 broad buckets people pull from when arguing for a particular intervention: mechanism of action, experience, and the medical literature. The story quality of mechanism of action and experience makes them extremely powerful and persuasive to our pattern-seeking brains. Hearing a physician tell a story about the time an intervention changed the life of her patient is far more moving than saying an RCT showed that for every 10 people treated with that intervention, 1 would have a 10% absolute benefit. Likewise, hearing someone explain the intricate pathway of how an intervention works sounds more convincing than someone saying, "I don't know exactly how it works, but well-run trials have shown it is better than other interventions in certain circumstances which it has been tested." Yet, for the bedside clinician, mechanism of action and experience should do little to move our predictions of whether or not they work. Their use as evidence in disagreements over treatment plans makes conflicts intractable because they are highly unreliable sources of insight into what actually works. Yet their pervasive use in conflicts demand that I try to disabuse you of using them because the weight we give them comes at the expense of learning how to read the medical literature. Let's start with experience. Chess players peak in their 30s, theoretical economists at 25, experimental economists in their 50s, and the average age of a Fortune 500 CEO is 55. This graph here on the left is a systematic review looking at patient outcomes as they relate to the numbers of years a physician has been in practice. 70% of the 62 studies showed decreases in at least some of the patient outcomes as a physician ages, and 50% of the studies showed a decrease in all patient outcomes measured. On the right is a 2017 study looking at over 700,000 admissions. And again, they found that the older the physician, the worse the mortality rate. There is, however, a large confounder in these studies. Older physicians tend to work less. Those that maintain higher levels of clinical activity do not see the same decline. The fact that a clinician achieves better outcomes by spending more time as a clinician is a finding that is not that interesting to me. It does not answer whether that experience gives better insights into what actually works. For example, if I'm going to have my thyroid taken out or have my knee operated on, then I want a surgeon that manages 100, not 10 cases a year. Similarly, if I have a neonate that is seizing, I want a neurologist that manages 50, not 5 neonatal seizures a year. Of course, the surgeon with 100 cases a year will be better at taking out my thyroid with fewer complications. Whether I should have the procedure in the first place is the real question. On the left is the graph showing the dramatic rise in the incidence of thyroid cancer due to increased screening, which ultimately led to a dramatic rise in thyroidectomies. This line on the bottom is mortality, which is unchanged. They were taking out indolent biology. The graph on the bottom right is sham knee surgery versus partial meniscectomy in degenerate meniscal tears. There are no differences in the outcome. The top right is the NeoLEV-2 trial. Despite numerous case reports and uncontrolled studies claiming that physicians were experiencing levetiracetam having an 80% success rate at stopping neonatal seizures, it only aborted 27% in a blinded study compared to 80% in the phenobarbital arm. Experience is illusory. Most things we try in medicine don't work, and we only tried them because we thought they would, either based on experience or mechanism of action. As Dr. Thomas Chalmers put it, one only has to review the graveyard of discarded therapies to discover how many patients have benefited from being randomly assigned to a control group. Forget all the bloodletting and mercury tinctures. In this era, with all our knowledge of genetics, pathophysiology, chemistry, and advanced computer modeling, 90% of the promising drugs that make it through rigorous preclinical trials end up failing in clinical trials. What's more, somewhere between 10 and 40% of standard practices that are tested in well-conducted randomized control trials are overturned. How are we, some of the most educated people in the history of the world, fooled by our experiences that we are still interpreting many interventions that have net harms as beneficial? We are pattern-seeking primates that struggle separating the signal from the noise. For example, I often hear people use placebo response and placebo effect interchangeably. The placebo effect is a distinct physiological response to the therapeutic context and treatment delivery. It is real, but is rarely quantified in studies. The placebo response, on the other hand, is whatever happens in the group assigned to receive a placebo. This includes natural progression of disease, regression to the mean, and the placebo effect. How much of the response is made up of each is different for different conditions. Let's start with seizures, because I do not believe a sugar pill reduces abnormal discharges leading to decreases in seizures seen in epilepsy trials. Yet on average, we see a 17% decrease in seizure frequency in the placebo arms in refractory epilepsy trials. Why is that? Here are the seizure diaries of 10 synthetic epilepsy patients that I randomly selected from a pool of 10,000 that I created by using Dr. Goldenholtz's epilepsy patient generator. To be included in a refractory epilepsy trial, you need to have an average of at least 4 seizures a month over a 2-month prospective baseline. The vertical dashed line here denotes the 8-week cut point, and the horizontal is the average of 4 seizures a month. Take a look at the hot pink line, which is patient 6950. That patient didn't meet the inclusion criteria as he was on a downswing during the prospective baseline. Yet if he had been included, it would look like his seizures got worse. Meanwhile, the purple and olive lines, which are patients 6683 and 4257, were peaking during the baseline period, so they were included in the trial, and then immediately showed a decrease in seizure frequency. Overall, by selecting patients based on frequency, you will see a natural regression to the mean. This natural regression to the mean is what accounts for the placebo response in seizure trials. In a recent paper, Dr. Goldenholtz and Dr. Westover used these synthetic patient diaries to explore the validity of their diary generator that is derived from seizure tracking data and RNS data. They used the diaries to recapitulate published seizure trials based on synthetic patients. Their model did exceptionally well, and they were able to account for the entire placebo response based on seizure frequency variability. And I was able to recapitulate their results as seen here. Each box consists of 200 trials of various sample sizes. As you can see, the placebo response in a sample size of 100 can be up to a 40% decrease in median seizure frequency. In clinical practice, you will be even more deceived, as these trials also try to exclude patients with high clustering by stipulating that there needs to be at least 3 seizures in each 4-week period of the 8-week baseline, and no seizure-free periods for longer than 25 days. They do this because seizure frequency has high zero inflation with clustering, which means that some of the patients will have a bunch of days without seizures and then cluster over a few days. If included, these patients would cause a significant issue with the placebo arm showing higher rates of seizure freedom during the 12-week trial. But you experience all of these patients in practice, not just the ones that are included in the trial. I assure you, the anti-seizure drugs we use work, but not to the degree you experience them working. Often you are treating natural variation that would resolve without adding a medication. By the time you take off the medication, the patient might have been ramping up, and then you conclude it was due to the decrease in medication. You can see how this might lead to polypharmacy. Lastly, I have heard some wrongly assume that if the inclusion bar is set low, then we do not have to worry about regression to the mean. They will often point to the median frequency of those included being much higher than the inclusion criteria. This is an understandable misconception, because regression occurs when measurements are not perfectly correlated, and extreme measurements at one time will tend to be less extreme at another. Therefore, by making a high bar into entering the trial, you could cause greater regression to the mean. However, you can see what happens to the group's median when you condition on 4 seizures a month. Although 4 seizures a month seems like a low bar to entry considering those that were included had a median frequency of 8.6, this median is dramatically shifted from the population of 2.9 because the inclusion criteria was conditioned on 4. And as we have already seen, this can generate on average a 17% reduction in seizure frequency. Moving on to the next component of the placebo response, I want to discuss the natural course of disease. To discuss this, I'm going to turn to pediatric migraines. Headaches, of course, are different from seizures, and I believe there is a real placebo effect due to personal perceptions of pain. Therefore, some of what I'm about to discuss is clouded by placebo effect, the regression to the mean, and the natural course of disease. We often think of natural course of disease when we think about a viral illness, where a patient seeks your help at the peak of their illness, and often, no matter what you do, they will get better. Talking about natural progression of disease does not seem as relevant in pediatric migraine. However, if you look at the 3-year follow-up of the largest pediatric migraine trial called the CHAMP trial, there was a consistent downward trend in headache frequency. This trial had randomized patients to placebo, amitriptyline, and topiramate. During the 3-year follow-up, less than 10% remained on medication. The results are interpreted that the act of taking the medication, whether it was placebo or not, got this downward trend going, as this graph here on the upper right shows that the headache frequency was stable throughout the baseline period. I agree that the natural course needed a shove in the right direction based on the numbers of years participants had migraines prior to the trial, but I do not think the act of taking a pill played as big a role as some believe. The baseline graph has a denominator problem. It represents only the patients that ended up in the trial. 10% of the patients were excluded from the trial due to not meeting headache frequency inclusion criteria during the prospective baseline period, despite having a high 3-month retrospective frequencies to qualify for that prospective baseline. If I went along to every month and excluded 10% of the patients that dropped below 4 headaches a month, the long-term trajectory would not be downward. This, of course, is a fair amount of speculation on my part because I do not have access to the actual data. However, the fact that the downward trajectory continued into the 3-year follow-up despite few people being on medication suggests that the natural course of the disease is playing a role in the placebo response of this otherwise chronic condition. Taken together, it is easy to understand how the history of medicine is filled with insightful people that experienced benefits from interventions that only had net harms. Because our experiences are so idiosyncratic and many of our best drugs only have a 10% absolute benefit between the previous standard of care or placebo, you could have a significantly different experience of one medication than another provider of that same medication. It is hard to accurately experience that kind of difference. You should trust well-randomized controlled trials over your experience, which might be a run of bad or good luck. Because of the randomness of our experiences, we should agree that personal experience should not be used as evidence to resolve conflicts arising from therapeutic noise. There's no way to resolve a disagreement when we try to one-up each other based on personal experiences that can be highly misleading. To sum up experience, it's kind of counterintuitive. If you are interested in being the best bedside clinician, I do not think you can sacrifice the time at the bedside. Patient outcomes will be worse. There are benefits in the act of doing. That said, you should not put too much weight into your experiences giving you insight into what works. Now to a brief turn of mechanism of action. To be clear, mechanism of action is super important to develop new interventions, and those clinician scientists that develop them will save more lives than I ever will. But I am talking about the bedside clinician. From a practical standpoint, I don't think we have the bandwidth to go to the basic science research articles and understand how it was conducted and how to interpret it. In the end, you still have to read the clinical trial data to see if it worked anyways, and we are barely good at interpreting those studies. The amount of hand-waviness that goes on at the bedside explaining the mechanism of action is often fairly amusing. I encourage you to go read the articles about interventions that we used to think worked and see how convincing the mechanism of action in that article seemed prior to being adequately tested in a clinical trial, or when we have a mechanism that seemingly should make our interventions worse, such as phenobarbital in neonatal seizures. Should you trust the mechanism of action, or would you trust the clinical data for phenobarbital in neonatal seizures? The latitude that physicians use when explaining mechanisms of actions creates intractable conflicts because we are complex organisms built over millions of years, and there are many different pathways that we can connect in countless ways. As an average clinician, I try to avoid doing mental gymnastics and stick to whether or not it works, than knowing exactly how it works. So again, I do believe we need to learn mechanism of action, but we need to sacrifice time somewhere, and this is one area where there is a mismatch in the current time allocation and its practical yield. At this point, you might be thinking this is all an academic exercise and doesn't apply to the patient in front of you if you can't rely on your experience and the understanding of the mechanism of action and how it applies to the uniqueness of every individual situation. Who cares if you are good at predicting the randomized control trials on clinicaltrials.gov? Does this actually translate to the bedside? I believe it does, because randomized control trials are our best tool at clawing the truth out of the messiness of nature. And if we are bad at predicting what interventions work in those circumstances, then we can't expect to do well at the bedside. Additionally, I think we should be making predictions at the bedside. We do this all the time. Every time we tell a patient they have high risk of seizure recurrence or a low risk of meningitis, or that it's not unreasonable to get a test, or explain which side effects are common or rare, we are making predictions. Yet this vague language is not helpful. Your definition of high risk is different from mine and different from the patient's. For example, when rare is intended to describe side effects between 0.01% and 0.1%, the average interpretation by the patient is 10%. Or when common is meant to describe a risk between 1 to 10%, it's on average interpreted by the patient as 60%. It's not even better between physicians. When someone said there was a low probability of disease, the range of physician interpretations was between 0 and 80%. It's no wonder that patients prefer visual numerical presentations of risk. It places everyone on the same page. In relation to this talk, conflicts cannot be resolved if we are using the same vague words, but we are interpreting them differently in our heads. I may better understand why you are so adamant against a treatment if you think the side effect risk is 10 times what I think it is, yet we are both calling it common. Rather than using vague, imprecise language, you can try to provide as accurate of predictions as possible for your patients. For example, you should try to predict the relapse rate of your patient with neuromyelitis optica that you put on eculizumab, or the % decrease in seizure frequency at 1-month follow-up when you add on an anti-seizure medication, or the 3-month modified Rankin scale after giving TPA, or the chances of a repeat febrile seizure in the same illness. It would be interesting to see if residency programs could train their residents to become more calibrated with higher resolutions as they progress through residency, and track their clinical reasoning based on something like a Breyer score. This might seem counterintuitive to recommend making precise predictions for your patients after I just explained why your idiosyncratic experiences provide little insight how effective a treatment is. If you only have a handful of NMO patients, then you could be misled by a few idiosyncratic responses. However, you would be making dozens of predictions a day on a variety of conditions, and your Breyer score would give you feedback on your thought process. Your score would be in comparison to others of your same training level. You would look at ways of improving upon that. For example, perhaps you did not account for the baseline differences in the NMO eculizumab trial, where more people in the placebo arm had failed rituximab prior to entering the trial, or that fewer were on concomitant immunotherapy, or there was possible informative censoring in the trial, or your patient lives a long ways away and the every 2-week infusion needs to factor into the chances that she actually receives the treatment. Additionally, the statistician Frank Harrell has some interesting ways to help make covariant adjustments for the patient in front of you, rather than blindly applying the average trial data to every patient. Of course, each prediction would have to be weighted based on the difficulty of the condition being treated, just as it would be unfair to judge a weather person in Kansas City to the person trying to judge the weather in Tucson, Arizona. Additionally, you can build in your level of uncertainty into your predictions, as seen here in the posterior probability distribution that I made combining the SET, ECLIPSE, and CONCEPT trial for status epilepticus in pediatric patients. This shows the range of what I think is possible for levetiracetam to stop a seizure. Although the results of any single patient will not be informative, a structured thought process that applies to all patients could improve your overall calibration and resolution. And this brings us to the final bucket of evidence that is too often neglected. The reason we should spend so much time learning critical appraisal skills is because randomized controlled trials, as mentioned before, are ultimately the arbiters of what really works and what doesn't. If you are not good at reading randomized controlled trials and predicting their outcomes, then it is hard to imagine being much better at predicting what works at the individual's bedside. I'm going to skip over the topic of observational studies and systematic reviews because if we're uncomfortable reading an RCT, then trying to properly assess an observational study or meta-analysis would be hopeless. Just as we ask people to describe what they see and not say GTC when referring to a seizure, we should also not allow ourselves to just say, oh, because an RCT said so. For example, here's a quote from the 2019 Consensus Statement for Evidence-Based Guidelines for the Management of Guillain-Barré. Although corticosteroids would be expected to be beneficial in reducing inflammation and therefore disease progression in GBS, 8 randomized controlled trials on the efficacy of corticosteroids for GBS showed no significant benefit, and treatment with oral corticosteroids was even shown to have a negative effect on outcome. 8 randomized controlled trials sounds fancy and definitive, but how many neurology residents have read these trials? Let's take a quick look. I can go into detail in all of these except Garcia because I couldn't locate it, but in the interest of time, can we please ignore the oral steroids group? The max daily dose was 80 milligrams divided BID. Also, the largest trial was of 46 patients. If you think this dose of oral steroids should count against steroids in general, then you'll have to rethink the optic neuritis trial. That leaves us with 4 trials. Can we exclude the 1976 ACTH trial, which had 16 patients that excluded patients requiring ventilation? If we include it, they showed quicker recovery for the ACTH group, but they also excluded a guy that was found dead at home, so there's that. The 1985 Garcia paper I can't locate, but there were only 20 patients. It was open label. The info I do have is that 7 out of 10 returned to work in the steroid arm versus 3 out of 10 in the placebo arm, but I really can't comment on this trial. That leaves us with the 1993 and 2004 studies. The 1993 study included patients with a GBS score of greater than or equal to 2, meaning they couldn't run, as opposed to the 2004 study that required a GBS disability score of greater than or equal to 3, which meant they required assistance to walk. Now, the length of the walking distance in the GBS disability score changed over the 10-year period that the 2 studies were conducted. But when you condition on a lower severity, there is only so much room to improve. You need more patients to find a difference. I'm sure that all neurology residents are familiar with the PRISM trial of aspirin versus TPA in low NIH stroke scale patients. It had roughly the same number of patients as the 1995 NINS trial, but it had lower power because it conditioned on lower severity. Lower severity can also narrow the therapeutic window as the absolute benefits can only be so much, and there will always be side effects of the medication. For example, we don't know why, but dexamethasone for COVID in the recovery trial helped those that required oxygen, but had a signal of harm in those that didn't. Perhaps more concerning, in the 1993 GBS trial, only 53% of the patients in the steroid arm received plasma exchange, compared to 65% in the placebo group. They said they corrected for this, but it makes me pretty uncomfortable that more than 10% of the patients in one arm got a proven effective treatment compared to the other. Additionally, the 1993 trial powered their trial based on changes seen in the plasma exchange trials. This makes no sense to me because now at least half the patients were receiving plasma exchange. You cannot expect the same effect size. Think about the antivirals in COVID. They looked great in the unvaccinated, but you can only improve so much in the vaccinated population because the vaccines are so effective. Your sample size needs to be much larger. Although the 2004 study conditioned on higher severity, it was powered under the assumption that 20% more patients in the treatment arm would meet the primary outcome of improving one GBS disability score as opposed to improving only a half in the 1993 trial. If we powered stroke trials to only detect that 20% of the patients would be doing better, then we wouldn't be an emergency service any longer, because the absolute benefit is 10%. Even with all these problems in these two trials, if you entered these trials, you probably would have wanted to been randomized to the steroid arm. The speed of recovery seemed to be better, which is consistent with steroids in other conditions. Perhaps there is no difference at 6 months. But if we don't care about the speed of recovery, then again we need to throw out the optic neuritis trial. Now, I'm not saying we should start doing steroids in GBS. I wouldn't put anyone on steroids unless they were in a trial. But rather than saying they don't work, I would predict that in patients with a GBS disability score of greater than or equal to 3 and are receiving IVIG, that there might be a 40% chance there would be meaningful shorter recovery times. And I would also predict a 40% chance that there is no difference, and a 20% chance that they might do worse. I wanted to end on this example for several reasons. First, it shows how saying RCT is not magic. We have to read the trials. Second, most people are used to me showing the problems in trials that show an effect, and they assume I'm negative about too many therapies. Third, I hope you were as surprised as I was by the quality of these studies. When I was first taught about GBS, people would rattle off that there were 8 randomized controlled trials showing steroids didn't work, so it sounded like the evidence was substantial. I have heard residents and med students being quizzed with the question, what is the dose of steroids in GBS? The answer, of course, is that you do not give steroids. The reason it trips so many people up is that many immune-mediated neurological conditions that receive IVIG also get steroids. The fact that it is taught with such confidence demonstrates we are not making honest contact with the medical literature. Lastly, it shows how a scout mindset might inadvertently cause more therapeutic noise, as I predicted the possibility of something working when everyone agreed it doesn't. This can lead to a lower quality of care and undo many of the advantages I spoke about with resolving conflicts. If everyone has their own hot take on a topic, then I expect more exploration off the beaten path. Of course, this type of noise can be generated by people using their own experience or mechanism of action, but using trials doesn't make us immune to this problem. This brings me to my final point, which is the value of clinical guidelines. I have as many problems with guidelines as the next person, but their noise-reducing qualities shouldn't be ignored. This is a diagram from Kahneman's book, Noise. Bias is how far the mean is from the true answer. Noise is the spread of the distribution. On the left is what happens when you reduce bias but not noise. On the right is the same reduction of noise without changing the bias. In the error equation, bias and noise are interchangeable. Reduction in one provides the same benefit in the other. It looks like the diagram on the right is worse as more people receive the wrong treatment, but in actuality, they are the same, as it is the average differences to the true value. Let me redraw the diagram and let's pretend steroids do improve GBS in certain circumstances. The guideline keeps everyone fairly tight and off the mark. Now pretend a bunch of people started questioning the ban of steroids in GBS and start being more liberal with its use. The use would get very noisy. Some patients would receive steroids in the right circumstances at the right dose, but many other patients would receive steroids at the wrong dose and in the wrong situation. It's easy to imagine how more harm could be done and more conflicts arise. I do question a lot of what we do in practice, but I don't venture too far from the standard of care or the guidelines. Not because I think they are right, but because I think they serve a purpose. Medicine is a team endeavor. I will leave you with the glimpse into a possible solution I have been considering. Hospitals often make their own institutional guidelines, such as this one from the Children's Hospital Richmond for acute headache treatment. Every so often, these are revisited and changed. The change can happen simply because a new person chaired the guideline and not any new evidence was produced. I would propose from the outset that several guidelines should be made based on the differing opinions of what might work. Then the guidelines would be deployed based on a multi-armed bandit model. At certain time points, say 6 months, there would be a random generator that selects a guideline to be used over a certain time period. Depending on patient outcomes, that guideline would get weighted up or down, and at the next randomization period, that guideline will have more or less of a chance of being selected. The goal is to strike a balance between exploitation, which reduces noise, and exploration. Of course, I would prefer a well-randomized controlled trial to settle our clinical questions. But I think this is a framework that incorporates a scout mindset from the individual level all the way up to the institutional level, which might lessen conflicts by having a structure that acknowledges our current state of ignorance and changes how we think about being wrong. And with that, I am done with this terribly long video. Let me know what you think in the comments down below. Thank you.